Good afternoon, everybody. I'm very pleased to welcome you to today's Nuffield Foundation webinar exploring the mental health impact of COVID-19. My name is Cheryl Lloyd and I'm one of the programme heads at the Nuffield Foundation and will be chairing the seminar today. Before we start hearing from our speakers, I want to explain that attendees will not be visible or audible during the webinar. However, after the presentations, I'll be putting questions to the different speakers. If you would like to ask a question, please do so using the Q&A function. You can submit these at any time during the webinar. And if you've got a question for a certain speaker, please do highlight this when you put your question in. We have a live closed captioning in English today. To turn this on, please click the CC button along the bottom of your Zoom screen. A recording of the webinar and a written summary will be available on our website shortly afterwards today. There's a lot of important points that we've got to discuss today. So without further delay, I'm going to introduce today's seminar. I'm very pleased to hand over to our Chief Executive, Tim Gardam, to set out the context for us. Over to you, Tim.
Well, welcome everyone, and thanks very much for coming. This is one of a series of seminars where we're bringing together related research findings from Nuffield funded and other projects to look at the complex impacts of COVID-19 on social well-being across the United Kingdom. And as CEO of the Nuffield Foundation, I just wanted very briefly to give you some context to today's research presentations and the discussion that follows. It was back in early March when the full significance of what was about to sweep across us was becoming clearer, that Nuffield sent out a call to the social science research community to put forward ideas on how we might track the developing impact of the crisis on people's lives as they experienced it. I think we'd all begun to recognise at that stage what was unfolding, and seeing it unfold so rapidly made us ask what could be the long-term social significance. But what we needed to capture urgently was data about the experience of these effects in real time, in a way that maybe more in-depth, long-term but retrospective analysis might not succeed in doing. And speed and rigour are often thought of as being in conflict in the academic mind, but on this occasion I think they needed to be in harness. And it was immediately apparent that the social science community was thinking in exactly the same way that we were. In a matter of days, our rapid response call for ideas was met with over 100 outline proposals. And in 5 weeks, we approved around a dozen projects on a wide range of subjects using a variety of methods across Nuffield's 3 core domains of education, justice and welfare. In addition, many of our other grant holders adapted their work that was already underway to address the impact of the pandemic on their core research questions. And I think what has been striking since then is how the timeliness of the publication of the outputs from these projects really caught the attention of policymakers and practitioners. And as the months have gone by, social science research has had the traction to inform policy just as the public health agenda has broadened to a wider one of social and economic well-being. Now, 6 months ago, of course, we were responding to what we supposed would be the distorting effects of an acute crisis, but one which we thought would have a definite duration. Today, we all recognise that we'll need considered research that will chart the long-term changes and hence the long-term effects that will continue to evolve as the uncertainty about the trajectory of the virus, and indeed our ability to combat it, continues. As we know, the pandemic has proved to be a catalyst. It both dramatises and accelerates disruptive trends in social inclusion, in education, in intergenerational and geographic tensions, in labour markets, and the wide intersectional inequalities that were already defining the character of contemporary Britain before COVID struck. So today's 3 presentations on the mental health impact of COVID-19 represent exactly the research ambitions that the Nuffield Foundation is here to support. 2 of the 3, the work of Daisy Fancourt and Ruth Patrick, have direct Nuffield funding. The third, Xiaowei Zhu's Institute for Fiscal Studies project, is co-authored with Nuffield trustee Professor James Banks. And it's worth pointing out that the Nuffield-funded IFS Deaton Review on Inequalities was at the forefront in identifying the disproportionate effect of COVID on ethnic minority communities. Now, a full summary of Nuffield's COVID work can be found on our website, and the link is in the chat on this Zoom page. And we would encourage all the Nuffield research community, as you take account of the findings from this seminar, to go on to discuss with us where the research agenda now leads as the implications of the pandemic continue to unfold. And so with that, I'm going to hand back to Cheryl, who's one of the senior Nuffield programme heads and has helped shape our COVID output, and she's going to chair the rest of the seminar. Cheryl.
Thank you very much, Tim. So we're going to be hearing from some great speakers on a really important issue today. We're going to start off with 3 presentations, followed by responses from policy and research perspectives, and then a discussion. We're going to be discussing the patterns in people's experience of mental health and wellbeing in the pandemic, how these are linked to other experiences, both prior to and during the pandemic, and what the government and other organisations can do to meet the population's mental health needs. So firstly, I'm very pleased to introduce Dr. Daisy Fancourt from the University College London, who's going to tell us about the findings from her Nuffield funded project, which has been tracking the social and psychological impacts on the population since mid-March.
Thank you very much, Cheryl. I'm hoping that you can all see my slides for this presentation. I'm going to be talking to you about the COVID-19 social study, and this is a project that we set up right at the start of the pandemic in the UK before lockdown came in to track the psychological and social impact. So the study recruited over 72,000 participants, adults living in the UK, and participants gave data once a week via online surveys. So the study's now been going for 27 weeks, and because participants were staggered as to which day they entered the study on, and therefore when they completed their follow-ups, it means we've had around 4,500 responses every single day over the nearly 200 days since the pandemic and lockdown began, providing us with over 750,000 completed surveys in total. So this has allowed us to track in real time the impact of the pandemic. So demographically, our sample is diverse. We used a number of different recruitment strategies that involved general convenience sampling through, for example, research networks and the media, alongside approaches that targeted groups who were less likely to engage via these methods. And statistically, we've been able to weight our sample to the proportions of the population in the UK. The topics that we included in this study were diverse. So they included things such as diagnosis and experience of COVID, attitudes to COVID, mental health and well-being, adverse experiences, social and health behaviours, and time use. And as well as the weekly questions, we've also introduced one-off modules that have come in for a week at a time that have allowed us to look at broader trait factors. So things like psychological factors, time use, previous and more in-depth adverse experiences, and other behaviours and social factors. And the study is very well phenotyped, so we've got very rich demographic data about our participants. The study has had 3 main outlets in terms of publications and data. We've been providing weekly reports which show descriptively what's been happening across all of our main measures. So in the same way we've had data coming out showing cases on mortality, we've been able to produce equivalent types of data on these psychological and social variables. We've also been providing scientific papers, and to date we have over 40 or 50 papers that are now in press or about to be submitted that cover the relationships between different factors and mental health and other outcomes in more detail. And we've also been providing additional analysed data to various parts of government, the NHS, Public Health England, the World Health Organization, and dozens of other community groups and third sector organisations. So these reports and papers are all available on our website publicly as well. And we've also done a lot of work trying to inform media and public understanding about the pandemic, including in the news, through newspaper articles, TV and radio programmes, podcasts and blogs and videos. So I want to talk you through some of the headline findings that we've had over the last few months from this study. And I thought I'd start by talking about trajectories of mental health during the pandemic. Now, we knew early on in the pandemic that population cohort studies in the UK would mobilise and gather data on things like the prevalence of mental illness during COVID. But as we knew these studies would take a while to be able to do their data collection and were only likely to be able to do limited amounts of data collection across the pandemic, what we tried to do in our study was to show the trajectories, to show when things got worse and what events or activities influenced that. So in the lead up to the pandemic, we know that mental health got worse for many people, perhaps with the anxiety of what was happening. So from this graph, you can see that in the weeks of March, just before lockdown came in, we saw quite a dramatic decrease in happiness and increases in things like stress, fear and sadness. Once lockdown came in, things actually started to stabilise and improve for many people. So we can see, for example, that depression levels stayed constant for a while, but then started to decrease even before lockdown was eased. And we saw a similar pattern for anxiety as well, and this stabilized across the end of August into September. Similarly, life satisfaction really started to pick up even during lockdown itself. But unfortunately, it's been a picture of quite stark inequalities in these experiences. So if we look, for example, at depression, we can see here that women had higher levels of depressive symptoms when lockdown first came in, and that this inequality has persisted. We have seen a slight narrowing of it though, which is encouraging. Similarly for age, younger adults had worse mental health at the start of lockdown. But again, we've seen some narrowing of this, particularly amongst 18 to 29-year-olds over the last few months. There were also interesting differences for people living alone who had worse mental health to start off with, whereas people living with children who had higher levels of depression but a faster improvement in those early weeks. But there were other factors where, in fact, we saw that there was not an improvement or a narrowing of experiences. So, for example, for ethnicity, income and mental illness, the differences that are apparent have maintained across this period. And there's even been some suggestion of widening inequalities, for example, as a result of income. The pattern is very much the same when we look at anxiety as well. These stark contrasts at the start of lockdown with some narrowing over the last few months for things like gender, age and living alone. But unfortunately, an actual widening of the differences for things like ethnicity and income. So this is a huge concern about mental health, is that it's very much not affecting people equally. And unfortunately, the groups who are being adversely affected are those who are already at higher risk. And it suggests that we might end up with wider disparities in mental health by the end of this pandemic. We've also been trying to work out what might have been underlying these differences. Why was it that actually mental health started to improve in lockdown? Because one of the concerns initially was mental health would get worse across lockdown as people became more isolated. Well, in fact, there are a number of factors that seem to have improved across this period. So if we look at life stresses, for example, we can remember that early rush on the supermarkets in the early weeks of lockdown, and we can see how this stress of getting food really decreased quite rapidly. Similarly, stresses around finance seem to decrease, perhaps as schemes like furlough were brought in, and mortgage freezes and other kinds of rebates. And also people's stress about catching COVID decreased. So whereas around 2/3 of adults were worried about catching COVID at the start of lockdown, this is now decreased, so it's now just over 1/3. But in fact, this is concerning because what we're actually seeing is that fear of COVID is actually very low overall. This is a scale that looked at physiological symptoms of stress when thinking about COVID. And we can see that nearly 70% of people were showing absolutely no physiological signs of fear about the virus. And only small amounts were actually showing what was considered a pathological fear, 2%. But we can see here that younger adults were more concerned about this, which is perhaps surprising given that they were less likely to be adversely affected by the virus if they got it. So it suggests that perhaps the higher levels of fear and reactivity to the events that were going on might have driven some of the differences that we saw, for example, by age in people's mental health experiences. We also looked at the relationship between these stresses, these worries, and also people's adversity experiences. So not just about whether you worried about finance, but whether you actually were unable to pay bills, or you lost your job, or you were bereaved across this period. And what we found was that there was a relationship both between experience of adversity, but also worrying about adversity. And in fact, it was very similar sized association in that worrying about adversities was almost as bad or as bad for your mental health as actually experiencing these things. And there are huge policy implications here, because it suggests that uncertainty over what's going to happen with things like jobs or finances can be a trigger for worsening mental health, even if schemes come in at the last minute that help to safeguard some of those adversity experiences. There's also another concerning pattern here, which is we looked at socioeconomic position, and we identified if people had evidence of being of low socioeconomic position. So we looked at a range of different markers and classified people as not being of low socioeconomic position or having one or two or more risk factors for it. So for example, being unemployed, living in social housing, having a low household income. And we found that the more low socioeconomic position factors people had, the stronger this relationship between worries and adversities and mental health. So in other words, those people who were having a tougher time were not only worrying more and more likely to experience adversities, but those things were having an even worse effect on their mental health. Finally, we looked at sense of control during lockdown and felt that many people were actually feeling out of control, whether this was about things like future plans, their relationships, their health, or their employment and finances. And again, when we look at this by age, we can see that younger adults were feeling the most out of control across every single domain. So this could also explain why we were seeing that younger adults were being most adversely affected from a mental health perspective by the pandemic. Finally, we've also looked at loneliness, which of course is very much related to people's mental health and really gives us an assessment about whether people feel that the social support and resources they had were meeting their emotional needs. What was interesting was that loneliness was pretty steady across lockdown and only started to really show some improvements as we entered into June and saw more releasing of lockdown. But as with mental health, it's important to consider how this compares to loneliness normally. And a number of data sources are now suggesting that loneliness has been higher during the pandemic than it usually is. We compared data from Understanding Society with our data looking at levels of loneliness from 2017 to 19 versus during the pandemic. And you can see that the proportion of people who reported feeling lonely often was nearly double during lockdown during the pandemic. We've tried to understand a bit more about these trajectories. So if some people are feeling more lonely, there might also be other people who are feeling just the same as normal. And when we look at this in more statistical detail, we've seen that there tends to be about 4 groups of loneliness. So these range from a group who were low levels of loneliness and potentially even had a slight decrease across the first couple of months of lockdown, versus people who ended up being higher levels of loneliness at the start and experienced an increase. And the bump that you see here coincided with Easter bank holiday weekend, when perhaps people who'd had social plans disrupted were more likely to be feeling the emotional consequences of that. What we then tried to do was to predict who would be in these different categories of this low, medium and higher loneliness groups. And unfortunately, we see again that younger adults, so for example, 18 to 29-year-olds, they were 6 times more likely to be in the highest loneliness group compared to adults over the age of 60. So again, a very clear inequality in loneliness experiences. We also found that people who had low household income were 33% more likely to be in that high loneliness category. Students were also over twice as likely to be in the loneliness category. And there was a clear relationship between mental health and loneliness. People with a diagnosed mental illness were 5 times more likely to be in that high loneliness category. There was evidence that some social factors were protective. So for example, people who were living with others were 75% less likely to be in that high loneliness category. And interestingly, people who had a number of close friends and high perceived social support, even if they weren't actually able to draw on that support during lockdown, that appeared to be protective. But there was an interesting finding here as well. We looked at people with a mental illness and said, well, if those people with a mental illness had good levels of social support or lots of friends, could that buffer the relationship between their mental health and loneliness? And unfortunately, it didn't. So in other words, mental health was still related to how lonely people were feeling, regardless of what their social supports and networks around them were. We also finally looked at the differences in the risk factors for loneliness before and during COVID. So whilst you can see there are some similarities here, like age continued to be a risk factor during COVID, as did income and whether people lived alone or not. What we also found here were there were some groups like students that actually came out as more prominent risk factors for loneliness than before the pandemic. And we can also see that the differences by age have been exacerbated during the pandemic. In other words, those people who were at risk for loneliness normally were also at risk during the pandemic, but they were potentially at even more risk than usual. There's a huge amount more that we've done on mental health, but in the interest of time, I'm not going to be able to go through it today. But just to give you a flavour, we've been looking at things like adversities and the relationship with mental health, particularly looking at the biobehavioural pathways that could explain this, like sleep. We've been looking at compliance with the rules on COVID and looking at the relationship with factors like mental health and happiness, as well as factors like politics and trust and compliance. We've been looking at time use, including things like volunteering and arts engagements, and things like health behaviours as well, and then looking at the interrelationship between these and aspects of mental health. We've also been trying to look at and identify protective behaviours, and we've now got a whole list of factors that seem to be associated with subsequent increases and decreases in mental health symptoms that we're preparing releases on so that people are aware of what factors can support their mental health during a potential second lockdown. We've also been looking at use of mental health services, particularly in vulnerable groups, and predictors of experiences like abuse, self-harm, and suicidal ideation. Finally, we've been looking at things like coping styles and how these predict people's mental health experiences across the pandemic. So moving forwards, we've got a lot more analyses on these trajectories over time of lots of these factors and the protective and risk factors. We've also been looking to do cross-national comparisons. So our data is just about to be released in our first cross-national paper, showing the similarities in mental health experiences with countries across Europe. And we also have a sister qualitative study that's involving interviews with over 200 individuals from 10 different vulnerable groups, so that we have more idea about the lived experience across this pandemic. And of course, we're continuing to collaborate with our partners to make sure these data reach decision makers as well as the public. If you're more interested, you can visit our website for more information about the study and to see all of our reports and papers so far. And I'm looking forward to discussing this later in the webinar. Thank you.
Thank you very much, Daisy. It's really great to have such detailed information about how things have really unfolded in that real time that you're able to talk about. So our next speaker is Xiaowei Zhu from the Institute of Fiscal Studies, and she's going to tell us about what they found when they were looking at how mental health in lockdown compared to what we might have seen if we hadn't had experienced the pandemic this year. So over to you, Xiaowei.
Perfect, thanks very much, Cheryl. Let me try to share my screen. Oh dear, this worked a second ago. Right, hope that's working. So I'm going to talk about some joint work with James Banks that tries to quantify the effect of COVID-19 on mental health during the first 2 months of the lockdown. So Daisy just now talked a lot about the trajectories of mental health over the course of the pandemic. What we tried to do in this study is to quantify the step change in mental health that was the result of the onset of COVID-19. So we used data from a longitudinal study called Understanding Society that first started in 2009 and interviewed respondents every year up to the last wave, which took place in 2017 and 18. And the advantage of using a longitudinal study that started before the pandemic is that we can track the same individuals over time and make sure that the differences in outcomes we're seeing are not driven by, say, different types of people self-selecting into surveys. So in April 2020, they launched the first of a number of COVID modules to track people's outcomes during the pandemic. And in total, we had about 12,000 observations with all the variables we need in our analysis. The Understanding Society survey includes the GHQ-12 questionnaire, which is a broad-based measure of mental health based on a set of 12 questions. So that includes things like whether you've had trouble sleeping, whether you've been feeling unhappy and depressed, and so on. And we construct 3 broad measures of mental health based on this GHQ-12 measure. So the first is just an overall score. So each of these 12 questions is scored on a scale from 0 to 4, with 4 indicating the worst levels of mental health. So one thing we do is just add them all together, create a scale of 0 to 36, which is called the Likert scale in the literature, and look at overall mental health. We then use 2 measures that try to get at the severity of mental health problems as opposed to just overall levels of mental health. So one measure we use is the Kaysen scale, which looks at the number of questions to which people have a score of 3 or above. So broadly speaking, that indicates the number of problems people have. We then also look at whether people have a score of 4 on any of the 12 questions. So broadly, that indicates whether people are suffering from any severe or frequent mental health problems. Now, you'll note that the last wave of the survey was conducted in 2017-18, and since then we would have expected some changes in mental health even in the absence of the pandemic. So we know, for example, that over the last several years of the survey, mental health as measured by this GHQ-12 measure has been deteriorating over time. So simply comparing the levels we see in April 2020 with the levels we saw back in 2017-18 would cause us to overestimate the effect of the pandemic on mental health. Crucially, the pre-existing trends in mental health differed across different demographic groups. So for example, the deterioration was stronger among young people. So such a simple comparison between the last wave of the survey and the April 2020 wave would also result in incorrect estimates of the relative decline between groups as a result of COVID. So what we do instead is we exploit the fact that we have data for multiple years before the pandemic to estimate an individual level counterfactual for people in our sample. And to do this, we account for differences in pre-existing trends in mental health by age and gender. We account for the fact that there's a sort of an age profile in mental health over people's life courses. So mental health tends to deteriorate up until around middle age and then improve in old age. And we also account for the fact that there are seasonal trends in mental health. So mental health tends to improve over the summer. And what that means is that a study that's captured just in April will differ from a sample that's captured throughout the year. And finally, we account for changes in people's individual circumstances. So in particular, people's economic and their family circumstances between the last wave of the survey in 2017-18 and in February 2020, just before the onset of the pandemic. So I'll start by talking about our estimated effects across the population as a whole and across different age and gender groups. And then I'll look at some analysis on whether the differential effects we find across groups can be explained by the differential impact of the pandemic on people's health and economic outcomes. So this chart shows the average GHQ score across a number of age and gender groups in the last wave of the survey, so in 2017-18. The red points here indicate women and the blue points here indicate men. And you'll recall here that a higher GHQ score indicates worse levels of mental health. So what you see here is that younger women aged 6 to 24 had the worst levels of mental health before COVID, whereas older men had the best levels of mental health. So the second set of points represents our best estimate of what mental health would have looked like in April 2020 in the absence of the pandemic. So as I explained before, we expect to see some changes from 2017-18, even in the absence of the pandemic. And finally, this third set of points shows the actual average GHQ scores across these age and gender groups that we observed in the April 2020 data. So there's a couple of things to note here. The first is simply that the overall average GHQ score went up by around 1 point relative to our counterfactual. And that's quite a large increase. So 1 point on the 36-point scale represents roughly the difference in average scores before COVID between those in the top 20% of incomes and those in the bottom 20% of incomes. It's also equivalent to the difference in the pre-COVID data between men and women. So women tend to have worse levels of mental health. This increase of 1 point is also double the increase in the GHQ score that we've seen over the last 4 waves of the survey. So over this period where there's been considerable alarm over the deterioration of mental health that we've seen. The second point to note is that the deterioration in mental health was largest among those groups that actually had the worst levels of mental health to begin with, so in particular among younger women. So we see here that in our counterfactual scenario, women aged 16 to 24 would have had an average GHQ score that was 16% higher than the population average, whereas what we actually see with the COVID data is that their average score was 27% higher. So it seems that COVID not only increased the prevalence of mental health problems overall, it also widened pre-existing inequalities in mental health. So that last chart looked at this overall GHQ score. We can also look at the other 2 measures that try to get at the severity of mental health problems. So the number of problems and whether people experience any severe problems. And we see that on both these counts, mental health deteriorated due to COVID. So the average number of problems that people report increased by 1, and the share of people reporting any severe problems more than doubled, from just around 1 in 10 in our counterfactual to around 1 in 4. Again, on these two measures as well, we see that the absolute deterioration was larger among young women than among older men. So again, widening pre-existing inequalities in mental health. Perhaps the exception here is this measure of any severe problems, where we see a large deterioration among older men as well. So far we've seen that COVID-19 led to a large deterioration in mental health, and that was more pronounced among younger people and more pronounced among women. So we could ask whether that difference in effects simply reflects differences in the material impact of the pandemic on people's lives. So for example, in previous IFS research and other research, we know that younger people have been more economically affected by the pandemic. So they've been more likely to be furloughed, more likely to be laid off, more likely to work in sectors that were shut down during the time the survey was taken. So bear with me here, I still have to find a way to present regression coefficients properly. So what we do here is, first of all, we regress the change in GHQ score on people's gender and age, and corresponding to the points I just showed, we see that women and younger people experience a larger deterioration in mental health, so more of an increase in their GHQ score. And we then run the corresponding regression, but controlling for changes in people's health and people's economic circumstances, as well as their family circumstances. And what we see here, adding this huge list of controls for people's material circumstances, is that actually differences in people's material circumstances does not explain much of the difference between these age and gender groups. So the coefficients we see up here are very similar once we include this full set of controls. So that was the change in the overall GHQ score. We can also look across the other two measures that we use. And looking across these results, we can get some broad indications of the types of circumstances that are associated with larger or smaller deteriorations in mental health. So for example, we see here, unsurprisingly, that actually having COVID-19 symptoms at the time of the interview is associated with a larger deterioration in mental health. But perhaps surprisingly, being at higher medical risk to COVID-19, based on this set of indicators, is not statistically significantly associated with a differential effect on mental health. Now, moving on to these economic factors, we see that being laid off during the period of the pandemic, having a fall in household earnings, and working in a sector that was shut down over the course of the initial lockdown is associated with larger deteriorations in mental health. But perhaps unsurprisingly, being a key worker is associated with having a smaller deterioration in mental health during that period. If we look at people's household circumstances, again, perhaps it's unsurprising, given school closures, that having a young child aged 0 to 4 is associated with a larger decline in mental health over the pandemic. Across all these three specifications, we also control for people's level of education, their ethnicity, the region they live in, whether or not they live in a couple, and whether or not they live with other people. And across all of these, with perhaps the exception of ethnicity, we don't see that these factors have a clear association with the degree of mental health deterioration. So just to summarize, the study tries to quantify the causal effect on COVID-19 on mental health in the UK by creating individual counterfactuals of what people's mental health would have looked like in the absence of the pandemic. We find a large deterioration in overall mental health that's roughly equivalent to the difference in average GHQ scores between those in the top and bottom 20% of incomes prior to the pandemic. We see that the deterioration has been largest among women and young people, which were also the groups that had the worst levels of mental health to begin with. So it seems like the pandemic widened pre-existing inequalities in mental health. And finally, we see that the differential effects across gender and age groups are not explained by the differential effect on their material circumstances. Great, thank you. Look forward to discussing it later.
Thank you very much, Xiaowei. Next, I'm pleased to introduce Professor Ruth Patrick from the University of York, who's going to present findings from their emerging evidence from her Nuffield funded project about the lived experiences of parents and carers living on low incomes during the pandemic.
Thank you. I'll just share my screen. Let's see. That was great. It's really, hold on, let's see, so start slideshow. Right, it's lovely to be here, and it's amazing. I've just been promoted to professor by Cheryl, so I'll tell the University of York forthwith, and I'll look forward to my. I'm only Dr. Ruth Patrick, but thank you, and thank you for that introduction. And it's really great to hear from the other two presentations as well. And it's kind of it's always hard to come third because you think, how am I going to follow? But especially because this is completely different. But hopefully that will be good, and it will complement well. But what I'm sharing today are some sort of early findings from our COVID Realities project, which Cheryl introduced already, and that's really different data, so it's sort of qualitative, rich data drawn from participatory work. So what I'll do first is I'll just introduce the study, and then I'll go on and summarise some findings from it. So the first thing just to say is that it's an 18-month research project that was very kindly and generously funded by the Nuffield Foundation as part of the rapid response that Tim spoke about at the beginning. And it's got a number of different kind of strands and work packages to it. And part of that has been about creating a space and fora for researchers of poverty to kind of explore how they adjust their work to new contexts, but also to kind of synthesize those research evidence bases that emerge and look at kind of scope for wider collaboration. But importantly, and what I'm kind of drawing on today, it also involves some new kind of participatory work, working directly with parents and carers living on a low income. And that was kind of motivated by the feeling that it was really important to understand everyday lived experiences of parents and carers living on a low income during this time, to gather that kind of real-time data that Tim talked about at the beginning, but to do it in a way that recognised and worked with the expertise that comes with experience. So the idea that parents and carers themselves, like living through this pandemic, had important experiences to share, but also there was a value in them actually contributing and being part of the debates about, you know, how things need to change potentially going forward. So people can get involved by going to our project website, which is covidrealities.org, and then they're kind of taken through some consent and they can sign up. And importantly, participation is really flexible and people can do as little or as much as they like. But the types of things that they can do is they can document their everyday experiences through an online diary. They can respond to a kind of big question of the week, which is posed sometimes by members of the research team, sometimes by participants themselves. And they can also attend monthly online discussion groups. So that process is ongoing. It started in July and we want it to run for a year. So a big challenge for us is sustaining engagement, so keeping participants involved and also responding and engaging to their ideas for what they want to do with the project as well. Okay. It's not letting me go forward. Yeah. Okay. So what mental health is important. Like mental health isn't like a core focus of the project, but when Cheryl and Molly invited me to speak at this, you know, I was really pleased to, and it was a very strong theme that's coming out of the evidence base from participants and from participants' accounts. And so what I've done is just kind of pull some of these out. And again, it's really, really different from what we heard from the first two speakers, but what's, I think it gets kind of some of the richness of people's experiences of mental health at this time. And remembering that these are all people who have a dependent child living with them at home and who self-identify as living on a low income. So Steph, who took part in the pilot study just from about June time, talked about how that experience of lockdown was really challenging for her mental health. So differently, I suppose, from Daisy's kind of broader picture reporting, but where old memories of being domestically abused have resurfaced. I'm not going to read out each and every quote because you can read them while I'm talking, but I think what Steph said that was really important is it's definitely affected my mental health negatively despite already taking long-term antidepressants. So we see that mental health impact worsening as a result of the specific conditions of lockdown. The other thing I wanted to draw out here was the experience of Danny, and Danny's 42 years old. She's working as a nurse. So again, like the participants that we're working with, we have people both in and out of work, and she's a single parent of 2 children. But she talks about kind of experiencing the 2 household rule and how, which was up in Scotland, and she felt a huge sense of dread. You know, lockdown was really hard. I was barely getting back on my feet emotionally and financially to start socialising again. And then the new rules were set. I couldn't afford the eat out to help out, so we never managed to do anything before the rule of 6 came into play. The isolation is really debilitating and the loneliness is crippling at times. So again, like reflecting back on some of the themes that we've already heard about. But I think importantly as well, that sense of exclusion. So for Danny, she wasn't able to kind of, there was lots of talk and chatter and narratives around, you know, let's get out now in the summer, we can eat out to help out. People that were living on a low income who couldn't kind of take part in those activities weren't able to, and then they felt maybe further entrenched isolation, loneliness, negative mental health impacts. Sadly, but not surprisingly, these negative impacts kind of flow down from the parents also to their children as well. So Dottie is a married nursing student and mum and one, and she talks about how her months have become filled with stress and anxiety and how to financially survive. And then what she talks about in this quote is going back to schools, going back in Scotland, but her daughter was refusing to go back. She was very anxious and worried about the new rules and guidance. But then she says, you know, I had a mad rush on then when the school said, you know, she should go back, to try and find a way to afford a school uniform for my daughter. And I think then we see the real clashing and the kind of duplication of the kind of difficulty with the kind of just the work of parenting and managing being a parent in this time of heightened stress, anxiety, but then also the financial difficulties when you're managing on low income. And so she's having to kind of manage her daughter's anxiety, but also manage trying to find the resources to just equip her daughter for school. The other one was, again, this is from Jasmine, who has a single parent of 1, and she talks about also having escaped domestic violence, but then and raising her daughter alone, then saying, I can't afford internet, so my child has not done her homework. She's basically been that bored, my child becomes self-destruct. So what she's talking about here is that how her financial difficulties make it impossible for her to participate in the activities that are being provided for her child, and that's then directly leading to negative consequences for her child, which are also impacting on Jasmine as a mother who feels guilt for that situation. The other thing that I wanted to flag is just the kind of work of parenting, especially on a low income in the pandemic, and the ways in which this can be very difficult and experienced in terms of kind of people's mental health effects, but also that people's children can also be a source and a resource in terms of how they respond in their mental health, which again kind of reflects back on what we heard earlier. So Nellie, I won't read this out, but what she's saying is she's talking about how she's struggling with her child's schools kind of changes that they've made to kind of cope with COVID, and that's tipped me into an episode of anxiety and depression. So sort of just feeling that kind of experience of watching her child go back to school, but it feeling very different, and that having negative impacts on her mental health. This quote from Lola is a really long one, but I thought it was really, really important in that she's talking first about her job as a key worker and how she kind of had continued working, but she was really suffering, you know, so again, like real in-work poverty that she's experiencing. She talks about that and the direct negative impact on her mental health. But she then goes on to say, you know, but actually, you know, that now I've got my children back home and there's lots of gardening and hours spent listening and laughing at my silly kids with their lovely, crazy minds and ideas. And she added some emojis at the end. So the fact that those children were actually sort of supporting and helping her at a very difficult time, their presence. This just slide, I just wanted to kind of pull out some kind of reflections that people are making in their diaries that will resonate with many of us, I think, and I think that's a really important thing to be mindful of, that we're all living through this pandemic, so sort of researchers, funders, the public health professionals alike, and so it's affecting us all in different ways, and I think that these two might kind of particularly resonate with many of us. So Connie, who's a single parent of 3, just talks about, although life continues every day, there's a feeling in the pit of my stomach that things are not right, and I think many of us will really identify with that feeling that Connie has. And then similarly, Holly, who talks about lockdown having a habit of getting the mind into repetitive what if narratives, and again I think that's something that will resonate with a lot of us. I'm nearly through these, but then the other one I just was about the real extent of kind of financial hardship that participants were experiencing, and the the very close and inevitable relationship between that, obviously, and then adverse mental health consequences. But Victoria, who's a survivor of domestic violence, just talks about, and these are kind of entries that people are writing as and when they want to, online. So, they have that kind of immediacy to them. But she says, hopelessness bites. I've got no money again until the end of the month. The food parcel we get are making me feel sick. All these high salt tin goods are giving me headaches and the runs. But again, and I won't read it because of time, but she goes on to talk about sort of the children and her enjoying the garden and trying to kind of keep going despite that, and hinting at the resilience that she and her family has. And then similarly, Zara just talking about how again, like just how she had an already fragile financial situation before the pandemic, but things were getting even worse. And she says, I'm constantly fighting with myself to keep my depression on an even keel, mainly due to my financial situation. I have to remain positive or I would drown. Okay, so just the last thing, just to say, we've heard a lot about the kind of social security response, and it's not a specific focus of this presentation, it's a specific focus of the project. But what we found, or are finding so far through the diary entries people experiences, are so far how far people aren't experiencing social security as a lifeline, and particularly although the £20 uplift to universal credit is experienced and talked about as very welcome, it's not making a difference for many people, about being able to manage. So Ted, who's an unemployed dad of two, just talks here about kind of following the government guidelines, claiming universal credits, but just not, I'm still really struggling. He says, I'm skint now and I need electric gas. I've got 5 days still to go. And he talks about, trying to shield his children from that feeling, saying, I can get anxious and emotional, but I can't be like this around child. Child thinks dad is a Superman. I wish, but I do push myself. So, so he's kind of experiencing that financial hardship, but then still trying to protect his children from it. And then finally, Teddy, who lives in Northern Ireland, single mother, she just talks about trying to access discretionary additional support, and the experience of that has been like humiliation and degrading, and makes you feel like you have to justify your existence to a stranger. So actually they're just an example, and it really chimes with the existing evidence base around kind of social security receipt and stigma and shame, but whereby additional forms of support are experienced in quite negative ways in the process of claiming them. Okay, so I'm like pretty much out of time, but just the reflections that I wanted to share. Obviously the negative mental health impacts have been really widely documented through this project already, and it was really hard trying to decide. There was just a real wealth of evidence, and it felt like I needed, none of you probably wanted this, but I needed like a whole webinar just to talk at length about it. But also I think something that's come through quite strongly is how a rhetoric of us all being in it together and going through this together really clashed with many people's lived experiences, and actually some of these key moments. So for example, the moving out of lockdown, they were actually experienced negatively by families who couldn't take part in and enjoy the things other people were going to. So if we think about Boris Johnson's announcement saying, come on, it's time to get out, go back and enjoy doing the things that you've done before. Many, they said, we just can't afford to do these things. He's not what's he talking about? And that was experienced as kind of driving further exclusion and senses of loneliness in a way. But also, parenting on a low income, we know this is already really, really hard work, but the last 6 months have, for obvious reasons, just made that only harder still. And the social security system is sometimes failing to support those most in need at this time. Just to conclude on a positive though, that participants in the project have really spoken about the value of being involved in the project and how that's actually had a sort of beneficial impact on their mental health. So the value of engaging in the research and meeting each other through the online discussion groups, that being important, and that being experienced as having a chance to connect with others who are kind of going through the same things. So that's all for me. Thank you.
Thank you very much, Ruth. Another kind of really thought-provoking presentation, understanding about how these things actually interact for people on a day-to-day basis. So thank you. We're now going to move into kind of the next phase of the webinar today to hear responses to the presentations. At this point, I'd also want to just encourage people to submit a question via the Q&A function if you have got a question on your mind, and then we can pick it up later on in the discussion. So firstly, I'd like to move on and introduce our first respondent, so Dr. Dami Kapadia from the University of Manchester, where she is also a QSTEP lecturer. Dami has been examining ethnic inequalities during this time, so I'm really interested to hear more about what is a really important issue on those.
Good afternoon, everyone, and thanks very much to the Nuffield Foundation for inviting me to speak here. Thank you very much for all three speakers.
I'm sorry, Dani, we're having some technical issues with just hearing you, so maybe can you try and just start again, and we'll see if that clears up. If not, we might go to James and then come back to you.
Okay, can you hear me now? Okay, so I was just saying thank you to all the presenters for really impressive presentations. I was really impressed with the level of data collection at such speed and the level of detail in the presentations that were presented. So I work at the University of Manchester, but I work for the Centre on Dynamics of Ethnicity, which is interested in understanding and documenting ethnic inequalities, both pre-COVID and now. And I also work with the Synergy Collaborative Centre, which is looking, it's a 5-year project funded by Lankelly Chase, looking to reduce the risk of severe mental illness for ethnic minority people and eradicating racism within mental health services. So I just want to pick up on like a few points that were touched upon within presentations and just give perspective from the research that we've been conducting and are due to conduct in the near future. So I think the one thing that the pandemic has showed is the wider vulnerability of ethnic minority populations. We know from previous research that inequality is present for these groups in a wide range of life outcomes in employment, access to housing, health, mental health, and the pandemic has exacerbated these inequalities. And we can see this from the increased mortality rates, especially for Black groups, Pakistani groups and Bangladeshi groups. And it's these groups as well that have been at most risk from losing, not having financial security. So working in shutdown sectors or having a lack of economic resources to mitigate the effects of the pandemic and the associated lockdown and restrictions. And all of these have an effect on people's mental health. And the work that we're doing within the Synergy Centre, which is looking at people's lived experience. So this is ethnic minority people with severe mental illness, their lived experience and how racism has impacted their mental health. This shows that cumulative experiences of racism in different areas from different state institutions at a structural level, institutional level and at interpersonal level has a severe effect on people's mental health. And I think just to link this to the Coronavirus Act and the changes that were brought in to the Mental Health Act, there were concerns raised at the beginning of lockdown that some of the rules that were changed for the Mental Health Act, where one rule was that only one doctor was needed to section someone under the Mental Health Act. There were concerns raised by many mental health charities, including Rethink, Mind and the Centre for Mental Health. And it will remain to be seen if this change in the rules of the operationalisation of the Mental Health Act has had an impact on the inequalities that we see. We already know from previous research that Black people are 4 times as likely to be detained under the Mental Health Act, and for South Asian people this is 2 times. So the next report from NHS Digital, which is due in the autumn, will be interesting to look at to see if these inequalities have been exacerbated. I think for people with severe mental illness more generally, there has been reports of lack of access to blood tests for people on medications such as lithium and clozapine, which has an impact on both their physical and mental health. And this is part of a more general trend which the Centre for Mental Health has reported on, that people at the beginning of the pandemic were not seeking mental health support from statutory services because they felt maybe their problem wasn't going to warrant attention, or whether there would be capacity for them to be seen. I think we're now seeing that those people who didn't seek help are now having to seek help in a crisis or in a more urgent way. But I think those people who have less severe mental health problems have also not been approaching statutory services. And some of the work that we've recently completed for the Greater London Authority, which was a systematic rapid review, has shown that ethnic minority people and others were relying on voluntary and community organisations for this mental health support. So VCSE organisations have been plugging this gap in mental health support, but often these groups are small, underfunded and lack capacity. And the requests that they receive are not, they can't deal with all of these requests. And they were getting requests for bereavement support as well. And that's an area that I think that has been neglected both within the research and policy contexts. And if we just think about the research that we have, the research evidence that we have available, or what might be missing. So the presentations did touch upon how things might be different for ethnic minority groups. But I think that quite often in these surveys, there is not sufficient disaggregation of overarching groups like the Black group or the Asian group. And even though this is possible to some extent with some surveys, it doesn't really get to the nuance of the different mental health problems and the different effects of these problems for groups, for different ethnic groups. And we are about to design and launch a new survey which is funded by the ESRC through CODE, the Centre on Dynamics of Ethnicity. And this will be a survey of 16,000 ethnic minority people. And one of the things that we will look at is their mental health under COVID, but we'll also look at experiences of racism and discrimination and how this has led to the exacerbation of mental health problems. And we'll be able to comment not only on the main ethnic groups that are usually enumerated within surveys, so these are usually the Black African, Black Caribbean, Indian, Pakistani and Bangladeshi groups. We'll also try to capture those who are underrepresented, such as the White Gypsy Irish Traveller group, smaller groups from African countries such as Somali groups, and also Jewish people. And this points to the fact that a lot of research studies, large-scale surveys and other research studies are not always able to access vulnerable groups and see the experiences of those groups, especially in pandemic times. And from the rapid review that we did for the Greater London Authority, some of these groups that are not being captured in research and adding to the research evidence are disabled people, the LGBTQ+ community, the prison population, sex workers and homeless people. And some of these are the most disastrously affected by the pandemic, with associated severe effects on their mental health. So where do we go from here in terms of what should be done? I think for the most vulnerable people with severe mental illness, there needs to be a reconsideration of some of the elements of the Coronavirus Act, and to think about how people with diagnosed severe mental illness are really suffering with lack of access to support services, medication, to wraparound care. These things are really very problematic for people who are very vulnerable in this way. For people who are suffering with lower levels of mental health problems, I think there is a space for talking about the solution to this as being access to digital counselling or online support groups, CBT, but this is really just treating a symptom of the pandemic rather than treating the cause of why a population as a whole may be feeling some deterioration in their mental health. And this points to more practical and economic solutions to mitigate the effects, the mental health effects of the pandemic, which is looking at things like a more comprehensive social security net, a wider range of organisations taking up equality impact assessment to see how people are being affected. And from our perspective as well, a commitment to race equality from national and local government. Thanks very much.
Thank you very much. That's really helpful and giving us all lots to think about, and also very helpful to know that that new survey is going to be launched as well, specifically looking at those vulnerable groups, which is really important. Finally, I'm pleased to welcome James Sanderson, who is Director of Personalised Care at NHS England and Improvement. He's going to give us a response from a policy perspective.
Fantastic. Thank you very much, Sharon. Good afternoon to everybody. It's very hard to summarise in just a couple of minutes all of the issues related to fantastic presentations there from Daisy and Shahawe and Ruth, and then a great response from Dami as well in regards to what obviously are really complex issues that we're dealing with in society. And We know in health terms, people living in the most affluent areas are experiencing life expectancy 10 to 15 years earlier than those in the poorest areas of society. We also know the significant societal demographic barriers that some people face to achieve the health outcomes that they would like to. When we look at health engagement in the NHS, around 40% of people living with long-term conditions say they lack the skills, knowledge and confidence to maintain their health in a way that matters to them. And I think that, I would say this as Director of Personalised Care, but I think personalised care gives us an opportunity to begin to tackle some of the issues we've heard the speakers detail. Starting with different conversations with people, I think, is really important. It's not just about a service-driven model. This needs to come from a place where we can start where people are at. We can ask them what matters to them, not just what's wrong with them, and we can look at applying what we call our comprehensive model of personalised care, because the complexity of the situations that we've heard documented in terms of the different demographic and societal challenges require a comprehensive solution. It's not just a case of providing an individual with a service. We know that most of what makes us well isn't what happens inside the NHS. And I think that what's come out of the last few months is a fantastic opportunity to reset the way in which we think about health and well-being. We've seen an amazing response from the NHS in terms of the clinical biomedical response and the frontline response to supporting people with COVID-19. But we've also seen a brilliant community response from the NHS. Before the pandemic, we were working on rolling out social prescribing across the country, and we have now in place 1,275 link workers who are people that will sit inside primary care to provide non-clinical support. We know that at least 1 in 5 GP appointments are from somebody who is lonely, socially isolated, maybe has housing issues, relationship problems, maybe is in debt. Some of those factors that Daisy was speaking about. And we know that actually to support those individuals, a biomedical pathway is not the answer. We need to provide people with support closer to them in their local community. We need to start embracing a biopsychosocial model. It's not about throwing out medical pathways, it's about looking at things that can work alongside. And that's where we think social prescribing has a massive role to play. And we've seen throughout the pandemic linking people to their communities. We've seen an amazing response from the NHS volunteer responders. And we've also seen link workers connecting with people living with some of the challenges that have been outlined by the speakers through getting them connected to community groups, getting them connected to online sessions, whether that's a telephone call for befriending, whether that's taking part in a community choir or physical exercise online, or whether that's manual things as well, like communities responding by delivering novels and jigsaws to people's houses to keep them occupied, especially for those that have been more clinically vulnerable of COVID-19 and have been shielding. We've also seen the great opportunity in the flexibility that personal health budgets can bring, and we're looking to significantly expand the number of people benefiting from a personal health budget. There's already a legal and personal health budgets have proven within the pandemic to be flexible by giving people the agility to manage their the services and support that they require in a way that matters to them and in a way that can be managed alongside some of the other challenges that we see in society. So my simple summary of what is an incredibly complex situation is actually, by starting from where people are at, by looking into the individual circumstances within which they're living, by looking beyond their medical condition and finding out what matters to them, we can start applying a comprehensive model of support through interventions like health coaching, social prescribing, peer support, personal health budgets, and opportunities to really create holistic support plans where the NHS can work alongside community groups and other providers to help people achieve the outcomes that they need to achieve. Thank you. Back to you, Cheryl.
Thanks very much, James. That's really helpful to hear your response. So now if we move on to the kind of discussion phase, I think one of the things that is particularly striking is that we saw in the data that actually the groups that there's the two things, there's a kind of the groups who we already know were much more likely to have instances, for example, of mental health difficulties, or from lower income backgrounds already, that we thought might, or we could potentially predict that might have suffered, and we've seen some widening of some inequalities in those areas during the pandemic. But there's also these kind of more surprising patterns that we saw, particularly, for example, in Daisy's data, about those who we might not have thought were at greater risk. So, for example, we've particularly seen younger people who have experienced more loneliness, for example, but actually haven't been necessarily at greater risk in terms of actually the kind of effects of COVID. So I suppose it'd be interesting to hear from you about how you think, given that we've had further restrictions in some localised areas over the last week or so, particularly being introduced, and also what might be coming in the coming months with further restrictions, how what we can learn from what we've kind of seen happen over the last 6 months might inform the government and other organisational responses going forward. I know, Daisy, you've been kind of talking, you mentioned, to different organisations, kind of particularly with a policy angle. Would you like to kind of pick up on some of those points and what your kind of, I suppose, recommendations would be, knowing your data?
Sure. I think one of the things that's been challenging is it's been relatively easy to engage with policymakers, with government, with third sector organisations, saying what the data is showing. But what's sort of been challenging is trying to get some of our recommendations through into policy. And obviously, as scientists, we've not been making specific policy recommendations, but we have been making recommendations at the level, for example, of focusing on student mental health and focusing on upfront addressing worries, as opposed to leaving things too late with things like finance or fellow schemes or whatever. But in fact, some of those areas are things where the recent policy decisions have actually exacerbated some of the issues. So I think we've got work to do to try and, as much as we are in control of this, to try and make sure that the decisions coming out are using the science as much as possible. So whilst we know that the data are getting to the right people, I think there's more work to be done to try and make sure that some of these challenges, particularly things that we're now seeing very clearly on the horizon as problems, are being addressed. And I think that could help with some of these inequality issues. And certainly one of the things we've been trying to point out is that the interrelationship between things like policies on benefits and financial support and what's happening in terms of people's mental health, and sort of showing that a lot of these structural factors that are being decided on from an economic perspective have such a strong relationship through to what's happening psychologically and socially.
Thank you very much. Ruth, is there anything from your emerging findings that you'd like to add to that, given kind of the complexity of the issues at play here?
Yeah, I think, I mean, it kind of reinforces a bit what Daisy says. I think it's the challenge of kind of getting the policymakers to kind of engage beyond kind of listening. I mean, we did, as part of the wider project, we were doing some early warning responses to the social security changes and then feeding them back to DWP. And I think there was a feeling that there was some kind of engagement in response to that. But there's also a kind of difficulty sometimes where we have, say, like a focus on the £20 uplift to universal credit, and that's kind of proclaimed as a really progressive, positive thing that they did to kind of in response to the crisis. But actually that conceals the complexity of the policy picture, where actually lots of people talking to in our study about not really getting it because they're still getting deductions taken because of the 5-week wait. If they're affected by the benefit cap, you know, it's made no difference to their income levels. So I think there's a kind of complexity of the picture versus the kind of some of the simple narratives that we get from the government that's often problematic. So
thank you. And I think kind of with that kind of related thing, we've had a question in for James actually about those kind of wider things, so particularly around social prescribing teams having picked up issues to do with housing and eviction, for example, and kind of rent arrears and that kind of loss of income, which is also proving a huge issue. James, is there anything you would like to kind of add to what you've already said on those kind of issues?
Yeah, I think you know, for a long time, a lot of GPs have tried to manage those issues, but have struggled because obviously they their time is very, very critical, and and a lot of GPs that you speak to say that sometimes as many as 40–50% of the appointments can be non-medical issues that people are coming to them, and obviously they're going to see a GP as a trusted member of society. GPs, often come out at the top of the list of index of trusted people in society. So the creation of link workers and the opportunities for social prescribing really can start to tackle, I think, those issues in a big way. And we're working with the Money and Pensions Advisory Service, for example, on debt management advice in particular, but also working across other advice pathways for housing support, for benefits, for legal advice, and trying to create those connections. And this is the bold step by the NHS. I mean, the NHS is investing £500 million in a network of what will become 4,500 link workers to provide this support and better connect people with the advice that they need through the various agencies and voluntary sector organisations in society that have always existed to provide that. But it's just another way of trying to improve people's health by non-medicalising the solution that's available.
Thank you. And I think Ruth might want to come in on that a bit more.
It helps if I unmute myself first. Yeah, it was just to say as well, like when we're thinking about kind of access to support in these new times, remembering the kind of barriers to some of the access, particularly to online support. So we heard there wasn't kind of time in my presentation to kind of cover that, but actually for low income groups, kind of the expectation that people will take part in online GP consultations or even just will be on phone, it's just not realistic. And I think that people have really struggled with those kind of changes, and there's been a real slowness to respond to that. And it's just an example where, and I mean, I would say this, but where there's a real value to actually working directly with people on a low income, because right at the start of the pandemic, groups on low income were saying, there's going to be a digital divide, we're not going to be access, education, and the policy response was really quite slow. So I think it's about saying, when we look at what expertise we value, I think it's really great and important, obviously, that we value scientific, academic, and third sector expertise, but let's also look at the expertise that comes from those groups that are directly affected by the measures that are happening.
Thank you very much. We've only got a couple of minutes left, so I thought it might be helpful to pick up, particularly on the points that Dami was making, kind of, I suppose, the challenges really in terms to us all in terms of the gaps, and thinking forward to, so we know, for example, spells of unemployment can negatively influence mental health, and we're anticipating unemployment to rise, and particularly as furlough kind of eases off. So I suppose thinking forward, there's a question I think I'm probably going to go around most of you with, but start with Xiao Wei, about thinking about how we might anticipate and plan for this and the other indirect impacts of mental health, in addition to the very kind of direct impacts of COVID, and how research, policy and the practice communities can collaborate to make sure that we have the evidence to understand and underpin those effective solutions that we're looking for from policy. So Xiao Wei, are you happy to answer that first? You're on mute.
I see, that would help. Yeah, I think as many people have highlighted already, there's a clear correlation between changes in people's economic circumstances and changes in mental health, and in particular sort of worrying about paying the bills, losing people's jobs, etc. So I think certainly there's lots more we can do in terms of trying to anticipate the economic effects across the economy. We at the IFS have done a lot already documenting how the economic effects have varied across different groups, including by ethnicity. Yeah, as the furlough schemes unwound and as we get more indications of what's happening to different sectors of the economy, there's certainly more we can do around that, and then sort of coordinating both the economic response and the potential mental health response.
Thank you. And Daisy, I know that you've got several papers in the mix, and there's been a particular request for looking at some more recent data in how the trajectories are unfolding. Is there anything you'd like to kind of add to Xiao Wei and others' comments?
Just to say that we're continuing to look at the trajectories. We originally imagined this as a 24-week study, and we've already gone beyond that, and we're definitely going to be continuing till next March as we take scope of the landscape. I think something that we're really keen to think about instead of changing the way we think about mental health during COVID is to imagine a bit like there are going to be 4 phases of mental health consequences of the pandemic. So that first phase we've been looking very much at people's immediate psychological responses, so their fear about the virus, their response to the first lockdown. But I think we've now got a second phase that's been emerging too, which is people's responses to the adversities. So, for example, to job losses, to bereavements, to these sort of longer term consequences from them. And I think we're also likely to be heading into a third phase soon, which is going to be the longer term implications of people, for example, not being able to access mental health services in the way they normally would during that first lockdown, and a similar thing with physical health services as well, and the consequences that's likely to have if people are now going to be getting diagnoses later or facing problems not at the prevention stage. And also, I think as we're starting to see, for example, the longer term consequences of people being out of work, so not just the shock of losing your job, but the implications that's going to have. And then as a fourth wave, thinking that this is not just going to be about COVID anymore, it's going to be COVID and a recession and a Brexit, which between them could actually mean that the very much long-term prospects of this in terms of things like poverty and environment will also be cumulatively adding to the psychological toll. So I think we really have to reframe our thinking on mental health for it being a long-term problem rather than something where we've seen a peak and now everyone's recovering from it. And I think this is going to be an important thing to be trying to get into the minds of policymakers and decision makers as well. So they're really hopefully trying to think ahead and plan for how we could try and reduce the burden of some of these later phases.
Thank you very much. I think that very much echoes some of the calls for that kind of more joined up cross-governmental approach on mental health, kind of integrating into the different policies throughout the department. I'm afraid that we've just gone over time, so I'm going to have to wrap up. Well, it's been a really interesting discussion. I'm sorry I haven't been able to hear from more of you in the discussion, the Q&A bit, because I think we could have spoken for much longer about all the different issues coming up. It's been really interesting to hear more about all the findings that are emerging from your work, and to really think about those forward-thinking issues, really, that particularly the ones that Daisy and Dami have kind of raised. So the discussion and kind of the presentation today have been really fascinating and given us a lot to think about. I hope the webinar has been useful for all the different people taking part in all different roles and organisations to all consider how we might better support mental health at this time. I'd like to emphasise that if you'd like to find out more, please do sign up to the Foundation's newsletter and visit our website. We've got information about all our different grants on there, and also information about how to apply for funding if you've something sparked a new idea for you during the session today. As the webinar draws to a close, I'd particularly like to thank all our speakers, so Daisy, Xiaowei, Ruth, Dami and James for their insightful and thoughtful presentations and responses, and of course colleagues at the Foundation, particularly Molly and Catherine, who've been very helpful behind the scenes on all of this as well. So thank you for listening and taking part today.